everyone, and welcome to the Surgical Ergonomics podcast, where we will be discussing everything related to surgical and procedural ergonomics, the people, ideas, and technology that will help enhance your physical wellness and career longevity. I am your host, Geeta Lal. I'm an academic endocrine surgeon, speaker, consultant, and surgical ergonomics coach. Having experienced work-related musculoskeletal injury myself, I am committed to increasing awareness of and developing solutions to counteract the impact of poor ergonomics on the professional and personal lives of healthcare workers in procedural areas. This episode of the podcast is sponsored by Pearson Rabbits. For many of you, your career is your calling, so don't let an unforeseen injury or accident take that away. Pearson Rabbits, a firm founded by a physician, specializes in disability and life insurance tailored for healthcare providers like you. They understand the risks you face and offer real education and guidance. It's about more than a policy. It's about peace of mind. Head to surgicalergonomics.com/podcast/ and click on the Pearson Rabbits logo to take the first step in protecting your future. Hello, everyone, and welcome to another episode of the Surgical Ergonomics podcast. In today's episode, I'm delighted to welcome as our guest, Dr. Ramon Cestero. Dr. Cestero is a professor of surgery at UT Health San Antonio and a nationally recognized trauma and critical care surgeon. A former Navy surgeon with extensive experience in combat and austere environments, he has dedicated his career to advancing surgical care through innovation and education. Dr. Cestero is the Chief Medical Officer and co-founder of Advanced Surgical Retractor Systems, Inc., and the inventor of the TITAN CSR Retractor, a next-generation surgical exposure system designed to address the longstanding limitations of traditional retractors and get consistent exposure with greater efficiency and improved ergonomics for the entire team. The retractor has earned national recognition, including the American Association of the Surgery of Trauma's Best New Instrument Award 2 years in a row. Expanding on this platform, Dr. Cestero continues to develop additional innovations, and his work reflects a commitment to improving surgical ergonomics, optimizing OR performance, and advancing technologies that enhance both surgeon effectiveness and patient outcomes. So welcome, Ramon, and it's great to have you on the podcast.
Well, thanks for having me. Pleasure to be here.
Wonderful. So, Ramon, we've shared with our listeners your sort of academic background and your current roles. I was just wondering if you might be able to share a little bit more in this regard. For example, where you grew up and where you trained and how you came to be at your current role at UT Health San Antonio.
Well, certainly. I grew up in Puerto Rico. I lived there until I was about 10 years of age. Then we moved to Southern California. I did all my medical school and undergrad at UC San Diego, then my general surgery residency at UCSF East Bay in Northern California. And then I joined the Navy when I was a resident. I immediately deployed, I think the day after my boards exam. I got on a plane and went to my ship in Kuwait, where I spent the next 7 months. And then I did several more deployments. I did a couple to Iraq and combat zone. And that's really where the need for a better retractor came to me, which I developed later. That's really where cemented the challenges in austere environments, which aren't too dissimilar from a operating room at 2 a.m. when there are a few people around, et cetera. And then I went back for fellowship training at LA County, USC in Southern California, ended up in San Antonio, where I'm at now with the Navy Research Department, where I ran combat casualty care research for the Navy. And then I converted to civilian sector at UT Health San Antonio, where I progressed along the academic ranks. And now I'm a professor of surgery and served as fellowship director for the trauma division, ICU director, and chair of faculty senate along that pathway.
Wonderful. Such a storied career. And it's interesting. I heard you say that you were deployed right after your boards to Kuwait. That might be something else we have in common, not the deployment, but I actually grew up in Kuwait, and I've been back since kind of with this ergonomics work that we've been doing. I was actually there last year at one of their big hospitals doing kind of a workshop, one-on-one coaching with the surgeons. So it's interesting, right? Like there's like always these 6 degrees or less of separation, when
Right.
people.
Right.
All right. Well, I'm sure our listeners will appreciate, your pathway, and I certainly do. But I'm going to dig in a little bit deeper. You said the environment, while you were deployed, kind of got you thinking about, specifically the retractor system. So, perhaps you could tell us a little bit more about how that interest, for example, needing retraction in an austere environment, then kind of tied into ergonomics and your innovation journey. Perhaps maybe in this you could also share what are kind of the limitations of the traditional retractor systems, and how they affect the ergonomics for surgeons and other personnel in the OR.
Yeah, absolutely. As I mentioned, I trained in the civilian sector, so as most of your listeners, and I'm sure you did as well. And this is a product for open abdominal surgery. So in that space, we have table-mounted retractors and non-table mounted systems. The non-table mounted systems, Balfour being probably the most commonly known one, is two metal ratchets or two metal bars on a ratcheted metal bar, which you insert in the incision, expands, at least you get the wound edges out of the way. Gets you operating, invented in 1911, same design as then. But at least it gets you started. It doesn't require an attachment to the table. You can start getting into the abdomen, controlling bleeding or whatever you're trying to do. It's very limiting, though, as far as the level of exposure, especially in the retroperitoneum, because you can't move bowel around. So for those cases, we'll normally move to a table-mounted system, a Bookwalter, an Omni, a Thompson. There's different brands available, which connect to the table, and then through a complicated contraption, you end up with some kind of ring or something supporting over the patient's abdomen. And then you can attach different kinds of blades that pull back and basically replace hands. So it hopefully minimizes the number of personnel involved. When you don't have either of those available, then you just get bodies. It's either medical students, residents, a tech, another surgeon, and now you're just finding personnel. So in a normal hospital, usually there's an answer to the challenge of providing exposure by finding one of those things. But when you're deployed on a ship, or especially in a combat zone where we're operating in tents or buildings of opportunity that we've taken over, we don't have the fancy things we normally have at home. So now we're really struggling. And so now you find yourself in a combat environment with most of the severely injured casualties you've ever seen, way worse than you'll see at home, with very limited equipment, very limited personnel. You're on a time clock because now you don't have platelets available. Maybe you're using just fresh frozen plasma and packed cells. So every unit you give, you're diluting yourself. And so there's just a lot of new challenges there. So the more efficient you can be ergonomically or just efficient in general, the better the outcome, because hopefully the quicker you'll control your bleeding. And so in deployment, I found myself multiple times. All we had was the Balfour. There were no options for table-mounted systems. And so we would struggle in controlling bleeding. And after doing that enough times, when I finally came home, I said, there needs to be something better than a product designed in 1911. And I found myself having similar challenges at 2 a.m. in a county hospital where you can't find individuals, et cetera. So that's really where the idea came for a better retractor that merged two very commonly used systems, but taking away their detractors. One, with the Balfour being fast, that's a great benefit. With the Bookwalter providing great exposure, that's a big benefit. But we took away the post and the inability to get down to the retroperitoneum.
Okay. So this is yet kind of another example, how a lot of the technology that we see, actually came out of work done in combat zones, right? Like this is not the only innovation. So tell us more then about this Titan retractor. I see you're wearing a Titan t-shirt, so I want to hear how you named it the Titan and why. And what's unique about this retractor system compared to the ones that we've just talked about, the non-post and the post options?
Absolutely. Titan name actually came out of just my wife and I thinking, what should we name this? It has to be something that's easily recognizable through a mask. It had to be something short. It's a lot of consonants, something that'd be clear and something trauma friendly. So Titan has, enough recognition behind it that it sounds like it's maybe a trauma related product. That came through some just trial and tribulation. The product itself is basically a combination of the Bookwalter and Balfour system. So it's essentially the ring for the Bookwalter, but split in half and maybe a little bit wider. So you get a little more lateral retraction. It's compatible with Bookwalter blades, so I've made it so that every hospital in the world already owns Bookwalter system equipment. I made it so that you could still use that and not have to throw it all away. But essentially, it's a ring with four blades, similar to the Balfour, that inserts in the incision, expands, really gets to the corners, but based on that tension, supports the ring above it. To then you can attach all the Bookwalter equipment that surgeons already know how to use. So when I was thinking about this, and now this is when I counsel new entrepreneurs, is
Right.
you want to make this as easily integratable into current pathway systems, education. If you make it too different, then you have a whole new hurdle to overcome. So this is equipment that people already know what the buttons kind of do, et cetera. So we merged it. I made it, the name Titan also refers to the fact it's titanium. So this goes
Mm,
to the ergonomics component. It's very light. It's 2.2 pounds, the entire system. So you can easily handle it, move it around. It can sit on the patient, but that small amount of weight allows you to place a lot of extra blades on it. And in fact, we make now titanium blades that attach to it to make it very, very lightweight. But it's easier to manipulate, but it's a titanium system. And two, also the ergonomic component. Oftentimes, a lot of our equipment can be assembled backwards. The Finichetto, the Balfour, even the Bookwalter blades can be placed in backwards by your assistant. I took that out of the equation. I asked my engineers, I said, it's very frustrating to me when it's handed to me and I have to stop, fix it. And it's just time. It's just time. And
yeah,
so I made it so it's only one-way assembly.
got it. This is so much valuable information. I just want to take a couple of minutes here to unpack, everything that you just said, not only for our listeners who are interested in ergonomics, but also budding entrepreneurs, as you pointed out. So you identified an issue with the equipment that we had, and then when you tried to address it, you actually tried to go into, as you said, existing pathways so that it wasn't too far off from what your potential customer base was already used to. They wouldn't have to relearn an entire new system. And while you were at it, you addressed one of the known pain points, which is that the retractor, the little attachments that go onto the ring, would be loaded in the wrong direction, and you'd have to redo that before you could deploy your blades. That was a sore point with me. I haven't done general surgery for a number of years, but I remember during training and first 10, 12 years of being an attending doing general surgery call, when you're trying to get the Thompson in or the Omni in, and the blades are kind of the opposite of where you need to be, and you're trying to do that. So I love that you described all this. So I suppose my next question would be, so you're thinking about this idea, this retractor. Did you self-fund the innovation, or do you have a biomedical degree engineer? How did you figure out, or do you have an engineering degree? How did you figure out how to make this happen?
Great question. So no, I do not have a bioengineering degree. I'm a general surgeon, like probably most of your, or trauma surgeon, just a run-of-the-mill surgeon, like most of your listeners. And so, but I was really frustrated by this ongoing challenge with exposure because it was not just during my deployments. It's when I came home and I would be in the middle of the day. I would start with a Balfour, typically for most of my cases, and then do I really need to put that post up? Because if I do, then I have to bring the nurse over. We have to clear the rail and then fighting with the post, and it's an extra 50 minutes. And let's not forget about the count, which stops the case because you've got to count the 150 items that are in the three trays for the Bookwalter. And so it's just a big hurdle to come over or to overcome. And do I really need that? And so it kept staying in the back of my mind. I eventually, when I transitioned out of military practice or service, and went to the university, I got an email that most of your listeners that are in academics probably have access to. It's the Office of Technology Commercialization, Tech Transfer Office. Every university has an asset like that to convert faculty's ideas into an idea and hopefully a product and maybe help society in the process. And so I received an email and I said, hey, I think I have an idea. Submitted it. They ask you to do a little bit of background. What's the market, do you think? Is it patentable? And then you do some basic research, submit that, and they do most of the legwork. And it turned out that this idea was patentable. They submitted patents. I partnered with the University of Texas, who owns my first two patents. And from there, found some funding for a prototype. Partnered, they helped me partner with an engineer that could take my concepts and thoughts into a potential product and how to draw it up, et cetera, AutoCAD. And so we eventually got to the point where we had prototype. And then it was a matter of how do you test it. I partnered with a research lab after the lab was done, and I was able to use a specimen to test out whether this concept of expansion on the abdominal wall really could support that ring without being too heavy, and then serve as a book Walter essentially without a post. And it worked. And from there, the university suggested that I maybe license it or form a company. And this could be a whole other discussion. There's two pathways, licensing and company formation. I eventually did company formation. From there, we got funding, friends and family around, et cetera. Again, longer conversation, but ultimately went through the pathway of funding, R&D, product, market research, and then design and commercialization. And now we've been out in the market for about 3.5 years. We're in about 90 hospitals or so. We're international, US and Canada, Army, Navy, Air Force use it, level one centers, community, and research labs even use it. So yeah, it's essentially a book Walter without a post.
Wonderful. Wow. So, as you kind of started talking, just a couple of minutes ago about this, and I had this visual in my head, I'm thinking, the number of times that I've stood next to one of these posts, whatever post retractor you have, and you're altering your posture to work around these posts, right? And the retractor blades. And not just yourself, you pointed out that you have to shift the nurse or your assistant, etc. And I must admit, I've come away sometimes with having, marks on my torso or on my leg from like the post, right? So certainly I can see how it would affect ergonomics of surgeons as well as their assistants and scrub techs, etc. So thank you for sharing that journey. Now you, as you said, you took this kind of through the university office and then ultimately ended up, bringing it to market. You've summarized it, in a really nice way, but I'm sure there were some challenges and lessons to be learned along the way, as there always are, right? Whether we're doing residency or whether we're innovating something. For the budding entrepreneurs among our listening audience, can you share some things that proved to be challenges and what you wish you would have known before you started on this journey?
Sure. So one thing I didn't mention is through this process, I did obtain my MBA, Master's of
Okay.
Business Administration. So when I started this in 2013 or so, was submitted to the university, and then it was a very slow process because I was full-time academics, and you only have so much time on weekends and nights to work on this, so it just didn't progress very quickly until I finally formed a company and really committed resources and time. That's when this moved along. So I think one of my lessons learned is that you do need to commit an immense amount of time to this to make it move forward. You expert, you are the advocate, you are the one who needs to move it forward. But if you've got too many other commitments, it is really, really, really challenging to do. And to hand this off to somebody else who isn't as familiar with it, isn't as enthusiastic, isn't as committed, it's just not going to move along as well. So the time requirements, I think, would probably be the biggest recommendation, is to really either plan for those initially, financially, socially, from a family perspective, et cetera, because you will need to devote a lot of time to be successful and finally get it to the across the finish line. So I think that's probably the first one. It will require funding. Unlikely that you'll be able to fund a multi-million-dollar product. And if you add complexity, FDA, any electronics, it is 10, 15, $20 million with multiple studies are required, et cetera. Mine was a fairly simple product. It will require funding. You probably will not be able to do it on your own. So you will have to fundraise. You will have to create a company. In order to get investors, they will need to see a return. So you need to know what your market is, who are your competitors, how much are you going to charge for this, how much are people going to pay for it, what is the value to the facility that's purchasing it. And this takes me to the multiple stakeholders you mentioned earlier, nurses, techs. This product actually benefits all of those stakeholders in the operating room, primarily
Right.
the patient, hopefully, but
Yes.
all the users. The nurse now doesn't have to come over and set up the post anymore and go back to his or her normal job. The techs can actually do their job without having one hand in the incision retracting and the other one trying to do the back table. The surgeon is more efficient. You don't have to take 15 minutes with the count, the setup, et cetera, and just move along with the case. Your assistants can now assist you rather than having handhelds, participate in the operation. So residents really like this because now they're actually participating rather than using handhelds. And then so really an SPD even, this is very lightweight. They don't have to open up the whole book Walter system. We have a modified set of ours that has all the blades. It's about 22 pieces instead of the 100 and whatever pieces. And so it really benefits all those. And that, having value to the entire surgical team rather than just the individual surgeon provides value to the facility, which then drives them to purchase it. And so those are all things that I learned along, using my network and learning from other people that had gone through this before, so I don't repeat the same mistakes. But yeah, there are many lessons to be learned, but primarily time and learning how a business really works.
Understood. And that's where your MBA came in, right? Because none of us are taught that piece. I'm also curious, you mentioned that the university, obviously, if you develop things at the university, then, there are patent laws and patent rights and, obviously use of their resources, etc. At some point, it sounds like then they don't own the additional patents. And I wondered if you could share, kind of how that occurred or evolved along the way.
Sure. Because it can be confusing. You're absolutely right. So when you partner with the university initially, it's really no risk, at least financially, to the individual or to the faculty applying. Really, they take on all the risk of the patent submissions and doing all that legwork, which can be expensive. If you don't know where this is going to go, then it's a great pathway. You get some guidance along the way. They can give you contacts, and especially being in academics, most of us don't really have those business, medical device development contacts. So it's really a nice way to get started. And so you can go that pathway. And then if you want to license that product, or the university does, you can serve as a consultant to whatever company comes in and says, hey, this is a great idea. We're going to develop it further. You can then consult back. And then eventually, if there's a contract between the company and the university, if there's any money made, then it comes back as a royalty to the individual inventor. It's a percentage of what comes back, but at least it is some kind of compensation. The other pathway is you can split off and form your own company, and then you license back your own technology, which is what I did. And I pay back royalties to the university that then filter back down. And if you develop new ideas or patents outside using university resources, then it belongs to the company. So we have several patents that we did in that manner that belong to the company and not the university. But the first two base patents for the Titan are really belong to University of Texas.
Understood. Thank you for explaining that. And I think some of our listeners, after they hear this journey and some of the other episodes that we've, had on the podcast, they're always interested in reaching out to sort of surgeon innovators, entrepreneurs like yourself. And I just want to let them know that I will include your LinkedIn contact in the show notes so that they can reach out to you and get some advice if they're interested in starting on this journey.
No, absolutely. I'm happy to help. I actually do a grand rounds on entrepreneurship now.
Oh, perfect.
So
Okay.
if anybody would like, I'm happy to do it. I know that it was a challenging pathway for me, but I'd rather not have somebody learn the same mistakes or go through the same mistakes I had and make it a little bit easier for them when they develop their product.
I think that's the surgical way, right? Like we say, do this way because I have learned the hard way why you should do it this way. Okay. This is, so kind of enlightening and amazing all in one. I had an additional question from like an end user standpoint, right? So when when I don't have help for my thyroid, neck cases, etc., I've gotten used to using like the mini Thompson retractor, the tiny blades. So I have to ask this question, does the Titan come in different sizes, and are there applications? I mean, I think you mentioned this, but I just want to verify that it can be used whether you're doing a trauma laparotomy, whether you're doing HPB, whether you're doing pelvic surgery, correct? So it's like broadly applicable. It's not just unique to trauma surgeons.
Yes, it has been used ranging from standard exploratory laparotomies for trauma to renal transplants,
Oh,
to,
okay.
to Whipple procedures, to surgical oncology, to rib fixation, and then most interestingly, Boston Children's Hospital used it for aortic surgery and congenital procedures for adults, and they used it for thoracotomy. And so it is very modifiable. So you can make I've used it for pediatric patients and large adults. So it ratchets out very similar to the Balfour. So the ring expands out based on the size of the incision. And
I see.
and actually in Department of Defense independent testing, we provide more surface area using our product than the Bookwalter does because we're wider. And so when you put four Buckwalter blades in the corners, it essentially takes the shape of the ring. And so we
Mhm.
actually provide more surface area than the standard Buckwalter system. So it's very modifiable for bilateral thoracotomies. You can turn it 90 degrees and it opens up this way instead of this way. It can be used
And
for
small neck incisions, maybe?
so when I was thinking about this, depending on the market need and market drive, it can be modified for different sizes because we've
Got it.
heard similar things from ENT surgeons.
Right.
When they're doing procedures, they're using just a hook to the drape
Mm-hmm.
and
Mm-hmm.
it moves. And so there are opportunities here in different spaces, whether it's orthopedics, ENT, surgery, and hopefully we'll get to that point in the future.
Wonderful. And we'll be back right after the short break. Surgeons and proceduralist colleagues, we train for years to master what we do, but most of us are never taught how to protect our bodies while doing our jobs. Neck pain, shoulder fatigue, back stiffness after long cases. For many of us, this isn't the exception, it's routine. I'm launching the first cohort of a virtual hybrid coaching program in surgical and procedural ergonomics, designed for clinicians who want to perform at a high level without sacrificing physical health or career longevity. The program includes 2 small group sessions plus 2 individualized one-on-one coaching sessions using PoseChecker, which is an AI-based motion capture system that provides personalized, actionable ergonomic insights both inside and outside the OR. I'm Geeta Lal, an endocrine surgeon with over 2 decades in the operating room and first-hand experience with the pain that comes from operating. I'm joined in this endeavor by Linda Miller, an occupational therapist and certified professional ergonomist, and together we bring real-world OR-tested solutions to you. If you're ready to invest in your performance and your longevity, email me at geeta@surgicalergonomics.com to get details and register. Your body is not disposable. Your career shouldn't be either. So, this actually brings me to another point, right? So now, whenever we're talking about this on the podcast, I always say we have data, objective data, that shows that wearing loops and headlights are both independent predictors of the time spent by surgeons in unfavorable neck positions. So the percentage of time in a case that they spend in awkward postures is proportional to the use of headlights and loops. Now, and this is kind of one of the reasons why I started the podcast, is so that we could kind of talk about various technology that might improve our day-to-day work, physical work while operating. So I heard you mention when we initially met that you're also working on or have worked on and have lighted retractor blades. I've used them I borrowed them from my breast surgery colleagues to use in the neck to kind of just remove the headlight out of the way. So can you tell us more about the lighted blades that you have? And are they as good as headlamps in deep cavities like the pelvis?
Sure. I teach, I'm an instructor for the Air Force for what's called the ground surgical teams. And these are 5-person teams that go out to austere environments and work in tents. They have to set up a tent in 60 minutes, do surgery. So really, really austere places. And I tell the surgeon, there are 3 things you need in this environment to really be successful and take care of a severely injured casualty. One is exposure. What is your exposure plan? Are you going to use a Titan? Do you have one? What do you bow for? Bodies, who's going to be those bodies, find them, etc. So you need exposure. Number 2 is you need lighting. If you can't see, especially in a dark environment, you won't be able to do surgery efficiently. So does your headlight work? Do you have an overhead? Is someone going to hold a flashlight? And again, this is austere environment, but these are basic concepts. And lastly is suction. If you have a IVC injury that just fills up every time you take your hands off it, you better have suction in order to get it. Now, in a normal U.S. hospital, we always have suction, but lighting and exposure, you better have a plan. And so, anyway, after exposure, I think I've solved that with this device. It's used well, and 90% of surgeons that use it want to get it in their facility. So the next challenge after exposure is lighting. So usually, and I'm glad you mentioned that, there are some physical aspects to surgery that can cause problems. It is more, for listeners that aren't general surgeons or trauma surgeons, it is a very physical sport when we have to get in there, especially in an obese patient. We're moving abdominal structures around and holding them up so we can get down to the injured vessel or whatever it might be. So you're leaning, you're over, and it can be challenging. So after exposure, lighting is the next problem. The lights are always over our heads. Normally in trauma, I don't wear a headlamp. I just usually don't have time. And so I'm leaning inside. to get the spleen out, and then I'm blocking the light almost every time. And so I said, the way we use the Titan is we always recommend 4 Richardson blades in the corners to really expand the incision. That's usually where we're having problems seeing. So basically what we did is we integrated a light tube on it, on the actual blade itself. This is just standard Richardson blade. So now it's just a light tube that you can attach something to. What we do with our device is you can, this is a battery powered pack. It's comes sterile, 90 minutes worth of light. You can attach it on the end, and now you've got light directed directly where your organ is or your corner. And basically you can just keep moving with your case. So it's efficient, it's ergonomic, there are no cords, you're not going to slip, no headlamp that you're kind of looking to the side as you've mentioned. And so now you just keep moving. So now it's lighting and exposure in one. Retractor blade's already pointed to the organ you're trying to get to. Now it's just attaching a light.
Wonderful. Can you hold that up again? Because I think you have solved another issue I've noticed with lighted retractors, right? So your light is actually, there's a lighted tube as opposed to like sometimes there's a frame, and when blood gets behind that little kind of covering, the intensity of the brightness goes down. So this way, you can easily wipe off that end of the tube because your source is actually in the handle of the retractor. So
Yep. And normally these are retracted so far up,
right.
give you better visibility than your hands typically don't get in here. And so rarely do I get blood here. And then
Understood.
it's also an ACMI connector, so you can actually attach it to a fiber optic cord for a brighter source if you need it. This gives you about 70 lumens worth of light.
I see. Okay. So lots of different things. This is why surgeons need to get into innovation, right? Because who understands the challenges of the equipment that we have? And we talk about this always in the Society of Surgical Ergonomics. And I've said, it's not enough to talk to the reps about the fact that the instrument is not ergonomic, or the size is not ideal, or the handle is not ideal. It's really important to get involved in these conversations because you have ideas, you can be consultants. You don't have to do what you did, which is inventing your whole thing. But if you can work with industry, it'll just improve the situation for everyone, right? And so, your journey highlights this so well, and I'm very glad that you are here sharing this with us. So in the last few minutes that we have, I have to ask now, you've spent your entire career in 2 different places. So military, austere environments, and then university hospitals with sometimes austere environments at night. So what are your ergonomic best practices that you have learned over this career, and what you try to impart to your trainees, fellows, residents, etc.?
Yeah, so I love this question because I actually am known for some of this, conveying some of these ergonomic things to residents as we're our fellows or we're training. So I think preparation is everything here. When you get to the OR or you go into the operating room, all your equipment that you want for your particular case should already be there. So prepare, make sure your nurse or tech, they know what it is you're going to need. Because if you tell them about it halfway through the case, then guess what? It's in central supply. And
yes.
All waiting around for the particular suture or whatever. So I always get to the OR early as they're getting the patient in, making sure, do I have 2.0 and 3.0 prolines on a CT1? Because that's what I like to use. Is the Titan ready? Is it assembled? Does my tech know how to assemble it so it's ready to go? Are the 2 lights along the middle of the table, not to the side? Because when you go to find them, then they're intertwined and you've got to unwind them, and now you're hurting your back and your neck. And it's just inefficient. And there are so many inefficiencies already in medicine and surgery. These are controllable variables that you can control and make your day just easier, fewer frustrations. And so I think preparation is all of it. Again, what's your exposure plan? Do I have enough residents? Do I have a fellow? Do I need to have to get somebody in? Who's it going to be? And those kinds of things, I think, it makes my day easier and faster. My job is to be efficient, to go in, do the case I need to do, and then move on to my next case, next consult, whatever it is. But I actually don't see as much of that. People get very comfortable in the operating room and just take their time sometimes. I think the less you're under anesthesia time, the quicker you're available to go do whatever else you have on your list for that day, the quicker you're getting home, more you get time with your family, et cetera, et cetera. But it all starts with preparation and organization. I think you have to be organized in order to be prepared.
Yeah, I couldn't agree more. I especially loved when you talked about that headlight, because that's what I do. I'm kind of like, we don't need the 4 that are standing there. We just need 2 in the middle, one right over the incision, one right above or below. anything else will just block because your head will come in the way, right? So, in the Society of Surgical Ergonomics, we're trying to incorporate these things into a ergonomics timeout. Just what you said, whatever you're going to need. And this might be also just before you get started, making sure you have the steps. The monitor is where you want. Let's say you're doing a lap chole on acute care surgery call, whatever. So those little steps, like you said, the preparation goes a long way in making the cases go smoothly, not just for you, but for the entire OR team. Think about what it does to the ergonomics of the circulating nurse running around trying to find equipment that you need, right? That's no fun either. So all of this is very much, I call these nuggets of gold, and I'm always amazed at how it doesn't matter what specialty or subspecialty you're doing, these things apply universally.
What's funny is, so we go to conferences now to now have a booth. I'm a vendor. We now attend Association of Operating Room Nurses because, as I mentioned, they're a stakeholder. They're part of this process, et cetera. First time we went, we had over 250 nurses come and visit the booth. And what I heard, not just once or multiple times, was thank you for inventing this for us. And it actually, I stepped back a little bit. I said, wow, I didn't appreciate how much of a challenge it is for them to bend over and get the post in there. They really do not like that. It's tough on their backs. It just really is unnecessary.
Right.
But it was much appreciated to see something like this that takes them out of that equation.
So with that, I think we're almost out of time. And so I do want to take a minute or so to again express my sincerest gratitude for accepting my random connection on LinkedIn going, hi, I see you have this retractor. I have a podcast. Would you like to be a guest on it? So thank you for connecting and for sharing the work that you do and for agreeing to be on this podcast. I'm sure we're going to get a lot of inquiries about the work that you're doing. And I'm excited about this episode when it airs.
Great. No, it was a great pleasure. Great to meet you. And thank you for what you do. I don't think there's enough being done in the surgical ergonomics world. In surgery, as you know, we're just taught to get through
Suck it up, buttercup.
And there's still,
let's call it what it is. It is that, right? Suck it up.
But why? Why? It's
exactly.
And so anyway, thank you for taking this on. It's culture change, right? As I've come to learn, but it is surmountable. And so thank you for doing this. Anything I can do to help, please let me know. Happy to do it.
Thank you so much again. So have a good rest of the day.
Hey, thanks so much.
Please remember to subscribe to the podcast and follow us on social media, Instagram, X, Facebook, and LinkedIn. We love feedback, so please reach out to us for topics, ideas, speakers, or if you ever want to be a guest on the show. Thank you for listening.